Early in human gestation, fetal tissues can sustain severe damage and regenerate seamlessly without a trace of a scar. By adulthood, that capacity is replaced by fibrosis, a rapid, structurally imperfect patching of the defect. This evolutionary trade-off favors speed over precision. Rather than reconstructing the intricate architecture of the original tissue, the adult body prioritizes closing the defect quickly to prevent fatal infection or exsanguination. This rapid closure depends on a synchronized, overlapping four-step sequence. It begins with haemostasis, followed by inflammation, then a lengthy phase of tissue proliferation, and finally, months or years of structural remodeling. Successful wound management relies on aligning clinical interventions with this biological timeline. The surgeon must identify which phase the tissue is in to remove the specific physiological variables that threaten to stall progress. Because this cascade operates within narrow parameters, understanding its baseline function is the only way to recognize when a routine injury deviates into irreversible pathology. When a wound fails to progress cleanly through these stages, often due to a prolonged inflammatory phase, the local microenvironment becomes erratic. Fibroblasts produce an overabundance of disorganized collagen. This biological overdrive typically results in one of two distinct formations. Hypertrophic scars push upward but remain strictly confined within the boundaries of the original incision. These often regress over time. Keloid scars, however, extend beyond the original wound borders, as seen in this child's torso and arm. These collagen masses fail to spontaneously regress and can be triggered by traumas as minor as a superficial scratch. When a surgeon approximates wound edges, they are performing a deliberate manipulation of tissue tension, attempting to keep the cellular response within these productive boundaries. The repair sequence begins the millisecond an injury occurs. Physical disruption of the vascular endothelium triggers immediate local vasoconstriction, exposing the subendothelial extracellular matrix. That exposed matrix acts as a chemical magnet. Platelets rapidly adhere, activate, and degranulate, releasing growth factors like TGF-beta, PDGF, and VEGF. Diffusing outward, these initiate chemotaxis and angiogenesis. Simultaneously, the coagulation cascade activates, converging on prothrombin, converting fibrinogen into a cross-linked fibrin mesh. This clot functions as a temporary biological scaffold, providing the structural infrastructure required for the next wave of infiltrating repair cells. Over the first 48 hours, the early inflammatory phase is dominated by neutrophils. Their objective is clear: hunting and minimizing bacterial contamination within the wound bed. By day 3, monocytes enter and differentiate into macrophages. They clear cellular debris and release proteolytic enzymes to chemically debride dead tissue. Acting as a signaling hub, macrophages secrete cytokines to drive fibroblast proliferation and the growth of new capillary sprouts. This transitions the wound into the proliferative phase. For the next several weeks, fibroblasts produce ground substance and type 3 collagen, forming the pink granulation tissue characteristic of an active repair. It takes a year or more for this structure to mature. The body systematically degrades the type 3 collagen, replacing it with stronger, highly cross-linked type 1 collagen. Despite this extensive rebuilding, the tissue reaches a permanent physiological deficit. Maximum tensile strength peaks at approximately 80% of uninjured skin. The body has reached stability, but it has left a permanent fibrous patch where highly functional native tissue once existed. While the chronological timeline is universal, the structural execution varies to meet the specific physical demands of different tissue types. In secondary bone healing, a hematoma is replaced by a soft callus, which solidifies into hard, woven bone. However, if a suture achieves absolute stability with internal fixation, the bone skips the callus phase, remodeling directly across the gap in primary bone healing. Peripheral nerves face a different challenge. When a nerve is severed, the portion distal to the injury undergoes Wallerian degeneration, a total breakdown of the distal segment. To reinnervate, Schwann cells recruit macrophages to clear myelin debris. They then proliferate to form bands of Bungner, microscopic tunnels guiding the regenerating axon back to its receptor. Whether the body is forming bone or guiding an axon, the baseline requirement is a stable, undisturbed microenvironment. Severe trauma, however, can physically dismantle this environment entirely. When extreme mechanical forces physically separate tissue layers, the biological engine stalls. The cells lose the structural continuity they need to communicate and migrate. This occurs in closed-to-gloving injuries, where shearing forces tear the subcutaneous fat away from the relatively fixed underlying deep fascia. This shearing force snaps the vertical perforating arteries, veins, and lymphatics that normally supply and drain the skin. Blood and lymph pool rapidly in the resulting dead space. This fluid collection keeps the tissue layers permanently separated, preventing granulation. This creates a Morel-Lavalley lesion. As this intraoperative photograph demonstrates, the internal tissue planes are physically divorced, making natural repair impossible without intervention. The surgeon must manually evacuate the fluid and debride necrotic tissue. By mechanically closing this dead space, they recreate the physical environment necessary for the cellular cascade to bridge the gap. Acute compartment syndrome represents a similar physiological deadlock. Here, interstitial pressure rises within a closed osteofascial compartment. When this internal pressure exceeds perfusion pressure, capillary beds collapse. Oxygen delivery stops, leading to profound muscle ischemia. Without oxygen, the healing timeline freezes. Macrophages cannot debride tissue, and fibroblasts cannot synthesize collagen. A fasciotomy resolves this by making long axial incisions through the skin and deep fascia. This physically expands the compartment volume and restores perfusion. Mechanical intervention is also required to manage necrotizing fasciitis, a rapidly progressing infection that outpaces the immune response. To restore the microenvironment, surgeons perform radical debridement, excising necrotic tissue until they reach a layer of vibrant bleeding. This bleeding is the definitive proof that the microvasculature is intact. Once the environment is reset, tools like the skin graft mesher seen here allow the surgeon to achieve definitive closure when the body cannot approximate the wound edges naturally. These surgical maneuvers are designed to physically reset the biological environment. By removing the obstructions of dead space, pressure, and infection, the surgeon clears the path for a failing cellular cascade to return to stability.